You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for May 30th, 2025. This week, listener feedback, CRT versus CSP, clues on the ECG, beta blockers after MI, novel approaches to LDL cholesterol lowering, and ICD decisions in cardiac sarcoidosis. First up is some listener feedback. Dr. Steve Dixon, a heart failure cardiologist from Kansas City, writes via email to push back on my persistent skepticism about rapid titration of guideline-directed medical therapy in heart failure. SD says, I am right about the strong heart failure trial, which used cardiologists for the majority of follow-up visits. And while CARDS-led care may currently be the case in many clinics across the country, he writes, times are changing. Hospitalists, PCPs, and advanced practice practitioners are becoming more comfortable with these life-saving medication classes, and the future of heart failure care isn't just the burden of cardiologists, but internal medicine, where there are more reinforcements. Dr. Dixon says that in his clinic, they use a 4 weeks, 4 meds program for patients with HFrEF, mainly through nurse practitioners that he guides and manages. He said it's quite an aggressive program, but I can assure you that my CEO of the hospital loves seeing his readmissions rates drop. Now, my comment to this is that I fully support programs like 4 weeks, 4 meds programs. It's a great idea. But of course, this takes administrative support. It takes champions, incentives. And I would add that this is a great use of advanced practice clinicians. I say congratulations, and I hope more programs like this became a reality. Clearly, heart failure care would improve if it did. The obvious advantage of such a program is not only getting more patients on maximal GDMT, but also avoiding harm from overzealous GDMT titration without adequate follow-up. All right, next topic, CRT versus CSP, the CONSYST-CRT trial. As many of you know, because I have said it so many times, the most exciting thing in EP right now is not catheter ablation, but pacing, specifically conduction system pacing. I saw a tweet or post or whatever you call it this week saying that ablation had become more anatomic and rote, and pacing is becoming more physiologic. And it used to be the opposite. In an ablation, we would map and study electrophysiology, and in pacing, we would simply flop a catheter in the RV, and we would just screw it in wherever it fell into the RV. But now in ablation, we put in a PFA catheter, and boom, E-grams are gone. I mean, PFA ablation is basically ruining EP. Now, during a pacemaker, we meticulously record and we pace in areas of the conduction system. 6 or so years ago, we were doing it with the HIS bundle, but now it's the left bundle. And to do conduction system pacing now is to bathe yourself in beautiful physiology. But beautiful images of CSP pacing on an ECG, that's not evidence. What we need is evidence that it is superior to BiV pacing for the treatment of patients with heart failure and left bundle. The thing is, in BiV pacing, we have strong evidence, right, from multiple trials that BiV pacing reduces heart outcomes like mortality compared to standard RV ICDs or medical therapy. Now, we think, and the emphasis on think, that because CSP, conduction system pacing, narrows the QRS, and because smaller studies have shown improved hemodynamics with CSP, we think that it is superior or at least similar to BiV pacing. But we need trials. Well, I'm happy to say that I'm a local PI here at my hospital for the U.S. government-funded left versus left trial, and we've randomized a number of patients already. Left versus left will have death and hospitalization for heart failure as a primary endpoint. Its planned enrollment is over 2,000 patients, and its follow-up is 5 years. So that's going to be a long time to wait. This month, Jackie P. has published another attempt to compare conduction system pacing with BIV pacing in CRT-eligible patients. Spanish investigators have now published a CONSYST-CRT trial. This was an RCT of just 134 patients. 134 patients of CSP versus BIV pacing. The design was non-inferiority of CSP. The primary endpoint was a composite of many bad things, right? Death, transplant, heart failure, hospitalization, or a failure of the left ventricular ejection fraction to improve more than 5%. Now, I hope you're seeing the problems already, and I'm going to go over the issues in the comments. The first finding of this trial was that 18 of the 67 patients crossed over from CSP to BIV pacing. That's a lot. Second finding, 23.9% in the CSP group had a primary outcome event versus 29.8% of the BIV pacing. That's an absolute risk difference of minus 5.9%. However, the confidence interval went from minus 21%, which is far better with CSP, to 9.2% worse for CSP. Now, the accepted non-inferiority margin was 10% worse, and so 9%, which is the upper bound, is less than 10%, and this allowed investigators to claim non-inferiority with a p-value of 0.02. Now, the secondary endpoints also favored CSP. Things like QRS narrowing was better in the CSP arm, the echo response was better, as was New York Heart Association functional class improvement. The combined endpoint of death, transplant, and heart failure hospitalization also showed non-inferiority, though I could not find any confidence intervals on the difference. The authors concluded that CSP was non-inferior to BIV pacing in achieving clinical and echocardiographic response, suggesting that CSP could be an alternative to BIV pacing. Okay, my comments. Look, I laud trials and clinicians who attempt them. It's great. The CSP versus BIV pacing is an important question. But if you're going to experiment on people, you need to have a chance of telling a difference. There is no way this trial had a chance with only 134 patients, and 1 in 3 crossed over. There was no way to detect signal from noise with this small number of patients and high degree of crossover. For instance, there were 16 versus 20 primary outcome events, respectively. There were 1 versus 3 deaths, 0 versus 1 transplant, and 8 versus 10 heart failure hospitalizations. The most common outcome was failing to improve EF, which is far from a hard clinical outcome. It's just a tiny number of events. Not only was the composite endpoint problematic, but follow-up for a year is totally inadequate. The left versus left trial is asking the same question, enrolling 2,000 or more patients and following patients for 5 years. Now, I think these small trials would be fine to compare hemodynamics, right? So that's a continuous outcome. You can measure that. But we already have oodles of those sorts of studies, and it really shows similar effects on the ejection fraction with CSP or BIV pacing. And in fact, some of the studies show that CSP pacing is maybe a little bit better for hemodynamics. I mean no malice to the Spanish team, and to be sure, I was part of the HIS-SYNC trial, which was another woefully underpowered trial between HIS bundle pacing and BIV pacing. But this type of effort tells us too little about the long-term effects of the two strategies, and I think underpowered trials should be avoided. All right, next topic is the important QRS complex. Since the beauty of the ECG is what interested me in cardiology to begin with, I am always on the lookout for studies on the ECG. A UCSF group reports a research letter in Circulation EP Journal on the association between a fragmented QRS and myocardial fibrosis burden and autopsy-defined arrhythmic causes of presumed sudden cardiac death. Now, my friends, QRS complexes should be sharp and narrow. There should be no notches or fragments. This is a report from the ongoing project called the POST-SCD, or Postmortem Systematic Investigation of Sudden Cardiac Death Study. The idea of the study is to use autopsy and clinical data to adjudicate arrhythmic, versus non-arrhythmic death. Why is that important? Because arrhythmic death is potentially treatable with an ICD, and non-arrhythmic death, such as overdose, PE, stroke, etc., is not. So far, the post-SCD team has had 943 presumed sudden cardiac death, of which 402 had ECGs before death, and 98, or about 1 in 4 of these, had available histological data. A fragmented QRS was defined as greater than 1 notch for the QRS if it's less than 120 milliseconds, and greater than 2 notches if the QRS was greater than 120 milliseconds, and fragmented QRSs had to be in 2 leads. The findings of this research letter were that presumed sudden cardiac death with a fractionated QRS on more than 1 lead were more likely to have arrhythmic causes compared with presumed sudden deaths without fractionated QRSs. It was like 76% versus 55%, so the odds ratio is 2.6, which was statistically significant. The team found no other ECG marker associated with higher odds of arrhythmic death. Coronary disease was the most common cause of a fragmented QRS, right? That's what we used to call peri-infarction block. Presumed sudden cardiac death with a fractionated QRS greater than 1 lead had a higher mean total and higher replacement fibrosis, as well as more interstitial fibrosis than presumed sudden cardiac death without fractionated QRSs. Now, I cover this imperfect study because the value of the ECG is under-recognized. I say it's imperfect because only half the presumed sudden cardiac death events had ECGs before death, and only a fraction of those had histological samples. What's more, the difference in associations were statistically significant, but the positive and negative predictive value of the fragmented QRS is surely low. I cover this study and discuss this as sort of a public service announcement to my colleagues in cardiology. Please, when you are sorting out whether a patient, say with syncope or near syncope, has a worrisome structural heart condition, study the QRS. When someone is telling me the story of a patient with syncope, my first question after the story is, what does the QRS look like? Fragmented QRS is an electrical manifestation of disordered ventricular conduction, which is often due to scar, and disordered conduction, aka anisotropy, sets the stage for reentry. Recall, one of the fundamentals of cardiology is that reentry requires 3 things: 2 pathways, delayed conduction, and unidirectional block. SCAR sets a stage for this because they have all 3 are possible, and 2 pathways can be functional pathways. In the same way that atrial structural disease increases the odds that a PAC fibrillates the atria, ventricular structural disease makes it more likely that a PVC fibrillates the ventricle. No, I am not saying that every notched fragmented QRS is malignant, but it's a clue. It's one piece of data. Don't overreact, but don't ignore the QRS. Okay, next topic is the ABYSS trial of beta blocker interruption after MI, and it continues to be misinterpreted. European Heart Journal has a substudy from the French ABYSS trial of beta blocker interruption versus continuation after MI. The substudy purported to show spikes in heart rate and blood pressure after beta blocker discontinuation, and that this explains why the ABYSS trial failed to show that stopping beta blocker therapy could be safely done in stable patients who were post-MI. None of this is correct. None. And I want to correct the record about ABYSS again. In my mind, the ABYSS trial is entirely consistent with the REDUCE-AMI trial of not using beta blocker in the post-MI patient with normal EF. REDUCE-AMI found that not giving long-term beta blocker resulted in similar MACE outcomes compared with standard beta blocker therapy in post-MI patients who had preserved left ventricular ejection fraction. The main ABYSS trial, published in New England Journal of Medicine in August of 2024, compared interruption of beta blocker or continuation of beta blocker in patients who had had a previous MI and an EF greater than 40%, and MI at least 6 months before randomization, and the median time from MI to randomization in ABYSS was about 3 years. ABYSS enrolled a lot of patients, 3,700 patients, and it had a non-inferiority design with a 4-point composite endpoint of MI, stroke, death, or hospitalization for cardiac reasons. The non-inferiority margin was a difference of 3 percentage points for the upper bound of the 95% confidence interval. And the results of the main ABYSS trial was that interruption was not only not inferior to continuation, but actually inferior to continuation. Here were the numbers. There was 23.8% primary outcome events in the interruption group versus 21.1% primary outcome events in the continuation group, so more. That's an absolute risk increase of 2.8% with a 95% confidence interval that went from 0.1 to 5.5, and since 5.5% was greater than the non-inferiority margin of 3%, non-inferiority was not met. And when you looked at the confidence intervals, the entire 95% confidence interval was above 0 for the interruption group, so it was actually inferior. But the entire composite was driven by hospitalization for cardiac reasons. It was 349 versus 307. There were no differences in death, MI, or stroke. The major MACE outcomes were nearly identical. The only reason that the ABYSS trial was found to be against interruption of beta blocker was a surrogate outcome, CV hospitalization. That requires adjudication. The less biased outcomes of death, stroke, and MI were identical. Now let me go to the European Heart Journal sub-study. This looked at changes in blood pressure and heart rate from baseline to post-randomization in 2 groups. The authors also assessed the changes in heart rate and blood pressure impact on the primary endpoint for the pre-specified subgroups of patients with or without a history of hypertension. And the main findings were, with little to no surprise, beta blocker interruption group sustained an increase in heart rate, on average about 10 beats per minute, and an increase in systolic blood pressure, on average about 3.7 millimeters of mercury. And these deltas remained stable after discontinuation over months. Now, with regard to the hypertension and no hypertension subgroup, which was almost about 50-50 split, there were largely similar effects. That was an increase in heart rate and systolic blood pressure. Also not surprising was that the primary outcome occurred more often in patients with hypertension than in those without hypertension, and this basically shows that hypertension patients are higher risk. But I'm not sure we needed that analysis because we've known for about 30 years that hypertension is a known risk factor. Now, the observed harm, a higher rate of the primary outcome, was numerically higher in the hypertension group for interruption. The difference was not statistically significant, however. In other words, this sub-study found no evidence of a heterogeneous treatment effect for hypertension and no hypertension. But remember, harm, in quotes, as described by the primary outcome in ABYSS, is flawed because it was driven only by CV hospitalizations. In Table 2 of the European Heart Journal paper, the authors show the results of the components of the primary outcome in the beta blocker interruption and continuation arm based on the subgroup of hypertension. And in MI, stroke, and death, the P for interactions were close to 1, as in absolutely no difference. The authors in the European Heart Journal concluded that interruption of beta blocker treatment after an uncomplicated MI led to a sustained increase in blood pressure and heart rate, with potentially deleterious effects on outcomes, especially in patients with a history of hypertension. Of course, my comments, my friends, the ABYSS trial is a perfectly nice trial. It addressed an important question. The problem was just a simple one, the choice of an endpoint. When you look at MI, stroke, and death, beta blocker interruption was totally fine. This sub-study showing why ABYSS found harm is flawed because the main trial chose a flawed endpoint to begin with. Further, finding that heart rate and blood pressure go up slightly when a beta blocker is stopped is like finding out you get wet when walking in the rain. Of course that happens. Beta blockers reduce heart rate and blood pressure, and when you stop them, heart rate and blood pressure will go up a bit. Since the main ABYSS trial found no increase in MACE, we can say that the small rise in heart rate and blood pressure don't have deleterious effects. The most we can take from this sub-study is that there does not seem to be a heterogeneous treatment effect for the presence of hypertension. So, I think we can stop beta blockers in patients with a history of MI if they have a normal EF and no other reason to take beta blocker. Now, the one caveat, some of you may push back, the one caveat to my argument that death, MI, and stroke were not different is that it's a little underpowered, right? For the composite of death, MI, and stroke, when you go back to the main Abyss paper in New England, the hazard ratio was 0.96, so no difference in the interruption versus continuation arm, but the confidence intervals went from 0.74 to 1.24. So that could be 26% better or 24% worse. But again, a little underpowered. And perhaps this is why the authors decided to add CV hospitalizations, because they knew that if you just had stroke, MI, and death in a post-MI group with a normal EF, those event rates are going to be pretty low. Yet, overall, I think if you combine, you take the totality of the data from REDUCE AMI and observational data from Denmark, the Abyss finding of no increase in MACE after interruption of beta blocker supports the idea that interruption of beta blocker after MI is reasonable and safe. And, of course, less medicine is always better. All right, next topic is about oral PCSK9 inhibitors in the Pursuit trial. Jack has published a phase 2 dose-ranging study with another oral PCSK9 inhibitor. This drug is called, funnily, AZD0780. In other words, it doesn't have a name yet. The drug has a novel mechanism, which I won't delve into at this point, but it did achieve a dose-dependent drop in LDL cholesterol. The maximum dose of 30 milligram tablet achieved a 50% placebo reduction of LDL cholesterol. And all of these patients were on statins and all had an LDL cholesterol greater than 70 milligrams per deciliter. Now, there were no adverse effects noted, but the study was quite short at only 12 weeks. The accompanying editorial was quite good. I learned a lot from it. First, I learned that there are multiple PCSK9 inhibitors in development, and I think this is a good thing because pills are better than shots. And I say that because shots increase the work of being a patient. There's just more inertia, there's insurance restrictions, and there's just more effort to take a shot, however infrequent it is, than to swallow a tablet. The editorial has also discussed the pricing dilemma and the role that pharmacy benefit managers will have. Now, PBMs are rebate-based pricing models, and they often dictate drug availability in the U.S. And to be honest, I don't quite understand PBMs anywhere near well enough to explain them. But I can also say that I don't get the feeling that PBMs contribute much to the health of U.S. citizens. Now, there is also a potential, and I emphasize the potential part, for permanent inhibition of the PCSK9 complex via CRISPR-mediated gene editing. Dr. Sek Kathiresan's company, Verve, is working on that, and it has progressed to early-stage human trials. This is a one-and-done approach to LDL cholesterol management. It's obviously a high-reward, high-risk strategy, and there will need to be rigorous safety data before this could become a reality. I mean, 2 safety issues have already arisen. One patient developed very high hepatic enzymes, and in another trial, 2 patients had serious cardiac events. These were not felt to be due to the intervention. So we shall see. I mean, there would have to be a heck of a lot more data on safety before I signed up to permanently change my genes, especially when you can accomplish the same thing with a tiny daily pill. And I know that I sound old saying this, but if you stop and think, it's quite shocking that such an approach could be close to becoming a possibility, right? Editing genes so as to reduce LDL cholesterol for life. That is remarkable. All right, the final topic today is on cardiac sarcoidosis and the risk of VTVF. One of the toughest calls in EP is deciding on ICD treatment of patients with suspected cardiac sarcoid. I mean, it's hard for many reasons, not least because the diagnosis of cardiac sarcoid and its risk stratification is super difficult. The European Heart Journal has published a nice study from a Dutch and 2 American centers. They had about 1,500 patients with biopsy-proven sarcoid. Now, mostly non-cardiac biopsy-proven, and these patients had not had VT and therefore were being considered only for a primary prevention ICD. There's not much controversy on aborted sudden cardiac death or VT. Those patients get an ICD, and we don't worry too much about that decision. The authors then compared outcomes based on multiple ways to risk stratify these patients. I, for instance, did not know that there were multiple professional societal recommendations for an ICD. For instance, there's a 2014 HRS statement. There's a 2017 AHA-ACC guideline. And there's a 2022 ESC guideline. And they're all a little different. The purpose of this study is that the Dutch and American authors propose a different way. They propose CMR phenotyping, and that it's better. Now, CMR phenotyping sounds tricky, but they actually made it pretty easy. In this study, you are either CMR high or low risk. It's based on ejection fraction and, quote, pathology frequent LGE, late gadolinium enhancement. They had 4 CMR phenotypes: no LGE in normal EF, no LGE in abnormal LVEF, pathology frequent LGE, and pathology rare LGE. Pathology frequent LGE included at least one of the 4 features. It had to be subepicardial, multifocal, septal, and right ventricular free wall involvement. The authors then dichotomized CMR phenotypes into simply high risk, which was pathology frequent LGE, and low risk, which were the other 3 groups: the no LGE in normal EF, the no LGE in abnormal LVEF, and the pathology rare LGE phenotypes. Their next step was to follow the 1,500 or so patients over 5 to 10 years for VT events. Of note, most of these patients were young, 54 years old. Now let me stop there and say that when you have a 50-something-year-old patient with heart block, before putting in a pacemaker, stop and think about sarcoid. Get your CMR and see if they have cardiac sarcoid. Now, the first finding was that when an ICD was indicated based on either the society or CMR phenotype, the likelihood of a ventricular arrhythmia event at 10 years was pretty high, and it ranged from 20% to 35% for the high-risk CMR group. When an ICD was felt not indicated by either the society guidelines or the CMR low-risk phenotype, the rates of ventricular arrhythmia were low. They ranged from 5% for the HRS statement to 2.6% for the CMR low-risk group. Now, the key finding of this study was in Figure 3, that the CMR dichotomized method used by these authors had the best area under the curve. At 5 years, it was about 0.86 for VT events, which is pretty darn good, and it was statistically better than each of the professional society criteria for choosing an ICD. The problem, of course, is that the ICD need is imperfect, right? A subgroup of the 1,500, about 8% of these patients, or 119 patients, received a loop recorder. And about a third of these loop recorder patients had a high-risk CMR and 2/3 had a low-risk CMR. 4 of the 38 patients, or 4% per year, had VT in the CMR high-risk group, and only 1 of 81 patients in the CMR low-risk group had a ventricular arrhythmia, and that calculates to 0.4% per year risk. And herein is the problem of prediction. Most high-risk patients do not have a VT event, and not every low-risk patient remains totally free of VT. And this is the same as it is for ischemic cardiomyopathy and non-ischemic heart failure patients. But I do like the CMR approach, though. And this study is quite nice, as there were more than 1,000 patients. All of them had biopsy-proven sarcoid. There was good follow-up, and the CMRs were centrally adjudicated and blinded. And there are, of course, limitations, right? ICD therapy as a VT event is not always a surrogate for sudden cardiac death. Some of these events were ICD therapies, and that doesn't mean the patient would have died. Just because a person has VT on an ICD and gets a shock or ATP, that does not mean it was aborted sudden cardiac death. The second limitation is that patients without ICDs in the study may have had VT and it went undetected. To me, though, if we had some replication or confirmation of such a CMR high or low risk strategy, it would seem like the best strategy, realizing, of course, the imperfect nature of prediction of ventricular arrhythmia events. The things to keep in mind with ICD therapy always, this is general rule of thumb, is that ICDs are never an insurance policy. Insurance policies confer no risk to the policyholder, and ICDs surely confer risk. Second general concept, you always want to deploy an ICD in a patient with a high risk of the primary outcome, the ventricular arrhythmia, and a low risk of competing risks, such as severe heart failure or dementia or CKD or a host of diseases that are seen in the elderly. Therefore, the 54-year-old patient with heart block and LGE and reduced EF from cardiac sarcoid seems like an ideal patient for an ICD. All right, that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review, and, of course, if you don't agree with something, write me an email. I always learn from these feedbacks. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.